こんにちは。神経心理学の授業の課題でプレゼンをしなきゃいけなくなったので、それの練習のためにこれからちょっと録音してみます。で、トピックはアルツハイマー病患者さんに対する動物介在治療の効果についてです。で、長さは一応15分以内って決まってるんですけど、ちょっと初めて通すのでもう少し長くなるような気がしてます。もし興味があったら聞いてみてください。でもそんなに面白くないと思いますよろしくお願いします。The paper I'm presenting is about the efficacy of the combined animal-assisted interventions with reality orientation therapy on Alzheimer's disease patients. Dementia is the second leading cause of deaths in Australia. Almost 500,000 people are estimated to have some sort of dementia, and the figure is estimated to double by 2060. Females are more likely to be affected by dementia compared to males. Dementia is an incurable terminal illness which presents a syndrome caused by a number of diseases. Of all, Alzheimer's disease is the most common, accounting for 60 to 70% of dementia cases. Dementia is associated with aging, but it's not an inevitable part. However, the likelihood of developing dementia increases as you age. Dementia affects the person globally on their cognition, communication, executive functioning, and eventually mobility. There are high variabilities among individuals in clinical presentations, as well as across the trajectory. There are two major pathological changes related to AD that occur in the brain, which are progressive and degenerative, which means it gets worse over time and the loss of connections and nerve cells will not be recovered. Both plaques and tangles are formed with normal proteins that we all have in our body that somehow transformed and act toxically and block the neuroconnectivities, which then causes the nerve cell wither and degenerate. This pathology tends to start in the temporal lobe, especially in the hippocampus in the early stage, and gradually spreads to the other parts of the brain, such as parietal and frontal lobes, which are in charge of higher order functioning and emotional control. This loss of neurons and synaptic connections leads to shrinkage of the brain that is accumulated over time. These pathologies are known to occur way before, sometimes decades, in a preclinical phase before any overt symptoms start to exhibit. At this stage, there's no cure options, and for pharmacological interventions, the medication to increase acetylcholine is often used, but it merely delays some symptoms for 6 to 12 months max. Because the medication doesn't treat the disease itself, the medication effect is eventually overtaken. Antipsychotic medication is also used, but patients often experience notable side effects. And both types of medications are known to have significant impact on patients' mobility and cause rigidity, as falling can be fatal, as well as with the polydrug tendency in old-aged patients, careful assessment is vital. For non-pharmacological interventions, as the disease is incurable, the focus of these psychosocial interventions is to enhance the person's quality of life by symptom management and providing meaningful activities for their physical and psychological well-being. More specifically, reducing agitation, aggression, depression, and maintaining and stimulating cognitive abilities are the focus of these interventions. There are plenty of different interventions, but at this stage the most promising ones are printed in green. Make a quick mental note of reality orientation therapy and reminiscence therapy, as they are currently regarded effective. Other interventions still have debates or problematic study designs, or just insufficient evidence available to draw a conclusive conclusion. But this doesn't mean that they're ineffective. One main theme across all these interventions is person-centered approach, where carers recognize the heterogeneity of dementia patients and tailor their interventions based on the individual's needs and strengths. There is no blanket intervention that works for everyone, as every person responds differently to each intervention. So careful observation and evaluation is key to providing effective interventions. So here are some visuals of a few non-pharmacological interventions, and especially reminiscence therapy's objective is to review past memories that are positive for the person and share those positive memories with other people around. Past memories are relatively well retained for AD patients, and reliving and connecting to those positive memories helps patients to regain their sense of identity and happiness. Dementia villages are getting popular in the world that were built based upon this approach, where you can see a replicated town of 1930s and 40s where current dementia patients grew up when they were young, because familiar environments make them feel safe. The term animal-assisted intervention is an umbrella term, and roughly there are two different categories: animal-assisted therapy AAT and animal-assisted activity AAA. So AAT is conducted for goal-directed treatment, whereas AAA don't have specific treatment goals and are done for a recreational purpose to enhance participants' quality of life. AAT provides individualized and tailored content based on the treatment goals, whereas AAA provides spontaneous content. AAT is provided by a professional with expertise, whereas AAA providers' training level and knowledge can vastly vary. However, these terms are not universally agreed and not used stringently in the reported studies, which has been causing some confusions and difficulties in comparing different studies. For theoretical frameworks, currently there's no widely accepted and empirically supported theoretical frameworks for AAI. And this diagram was extracted from a systematic review of AAI for cancer patients, because I thought it's showing the whole picture of the current possible frameworks, but it's not for dementia patients, so caution is needed when interpreting this information. So previous studies show that engaging in AAI has significant effect on people's physiology, such as increased oxytocin release and reduced cortisol, heart rate, and blood pressure. However, each mechanism overlaps and interplays with one another, making it hard to isolate each mechanism and its pathway. Also, the major problems of current research are mostly case studies and qualitative data reported, or even quantitative data lacking the basement measurement and a control group. Considerable methodological variations or flaws, thus yielding conflicting results, which makes it impossible to draw a conclusive conclusion of the effect of AI. Reality orientation therapy is one of the most widely used management strategies, where a facilitator or carer orientates the patient to the present moment by using various cues such as a clock for the time or a calendar for the date. The rationale behind it is that when a person is confused due to memory or cognitive impairment, it leads to social disengagement. So the orientation to the present will stimulate their cognition as well as enable them to regain a sense of control and confidence to re-engage with people around them. ROT can be delivered in two modes. Classroom ROT is delivered by a facilitator in a structured way, usually in a group setting, and 24-hour ROT is embedded in everyday care routines. Previous RCTs of ROT showed significant improvement in cognitive functions of dementia patients, but mixed results in behavioral problems, as overuse of ROT can make the patients realize their confused state repeatedly over and over and can sometimes demoralize them. They also showed that both ROT only and the combined ROT with other therapy forms contributed to a significant improvement in cognitive function of dementia patients, but the combined ROT didn't show a greater effect compared to ROT only, and none of them was combined with animal-assisted interventions. So the current study will examine efficacy of the combined AAT and ROT on Alzheimer's disease patients. The study was conducted at an Alzheimer's daycare center in Italy between January and June 2013 for 6 months. The motive behind this study was that the patients were not responding to the conventional non-pharmacological interventions. There were 50 mild to moderate AD patients randomly selected by the head geriatrician out of patients with no behavioral disorders. The patients were considered relatively homogeneous in terms of their age, sex, severity of AD, and depression level. The study had 2 experimental groups and 1 control group. The first experimental group received a course of AAI based on the ROT protocol. The inclusion criteria were no fear or aversion towards the therapy dog, they're willing to interact with the dog, and a personal history with animals. The paper didn't include the rationale behind this particular inclusion criterion, and we don't know what kind of decision were involved in the last criterion. The second experiment group received ROT only, and the control group had no stimulations. Each intervention occurred weekly for 45 minutes over a 6-month period. In this table, you can see that for both ROT only and the combined ROT plus AAT sessions, the basic structures are very similar, except for the combined animal-assisted therapy sessions. The dog was embedded throughout the session. The study used 2 measurements, mini mental state examination for cognitive functions and geriatric depression scale for depressive symptoms. MMSE is comprised of 30 questions, and the lower the score is, the severer the cognitive impairment is. The version of GDS they used was the 15-item version, but somehow they used the scoring of 30 as the full score. The higher the score is, the severer the depression symptoms are, and they used the score of 11 as a cutoff score of the existence of depressive symptoms. They administered these 2 measurements, both pre and post the 6-month intervention, for data analysis. Comparing the mean scores of the pre and post within the group was done with repeated measures t-test, and comparing the mean scores between groups was done with one way between subject and over with the Bonferroni poster comparisons. For within group pre and post comparisons, both the combined AAT and ROT only groups showed significant improvements at the post measurement compared to pre-measurement for the both depression and cognitive measurements. Although for the ROT only group on the cognition measurement, the post-mean score on the graph seems a bit misrepresenting, so please be mindful when interpreting the graph, but they said it was a significant increase. The control group remained unchanged from pre to post-intervention for both measurements. For between groups comparisons, the ANOVA revealed that for the post-measurement, both depression and cognitive measurements, there was a significant difference somewhere among those three groups. The post-hoc comparisons show that both for depression and cognitive measurements, there was a significant difference between the mean scores of the animal therapy group and other two groups. For the discussions, the authors attributed the greater improvement in AAT group to the increased participation rate in AAT therapy. They also commented that the composite RAT plus AAT succeeded because those two therapies affect on different domains, so RAT for cognition and AAT for emotion, and that is why the composite therapy worked better than ROT only. The limitation they listed included the study design not being randomized and double-blinded, which is hard to achieve for any animal therapy. Small sample size, no follow-up measurement to see the longevity of the effect, and not excluding the relationship factor with the team and the dog, because there was only one therapist and one dog. But they concluded that animal therapy based on RAT protocol is more effective to improve Alzheimer's disease patients' mood and cognition than RAT only. And these are my personal comments about this paper. So first, they didn't mention novelty effect that can often occur for animal therapy, that patients increase motivation and have lifted mood initially that can impact on the participant rate and results. But this effect can also habituate eventually, but we don't know when. Second, all the participants in animal therapy group had a personal history of owning a pet, but the experience of establishing an attachment with animals in the past and how those particular population would respond to AAT were not discussed in the paper. And lastly, AAT group activity involved in participants talking about their pets in the past. So this can be seen as a reminiscence component because they're talking about the positive memories about their past pets. And so the improved result might be confounded and not purely due to animal-assisted therapy. For future research, for Alzheimer's disease, medical science has been looking at new drug trials and developing biomarkers to detect early signs in the brain. For AAT, improving the research design is an urgent issue, with an adequate sample size establishing common measurement tools for direct comparability, more longitudinal studies, and more RCTs needed. For the areas to further explore, as empirical research on AAT is in its infancy phase, there are a lot to be researched, and such as animal welfare, optimal duration and frequency of the therapy, target population, and the list goes on. So, thank you very much for listening. お疲れ様でした。